Right now, I want to bring up Dr. Lowell Anthony. Please give him a warm welcome.
Well, it's a real pleasure to be here in the Midwest, I guess. We've moved up from the Southeast, and this is really a novel opportunity for everyone today. The program I've just put together, just found out as I walked in the room this morning that Dr. Vinnick was also talking about some of the same things I did, so I went in and changed my program. I went back and told him that I deleted the things that overlapped, and he told me that he went back and deleted the things that his overlapped. So now we both are not talking about what we thought we both were talking about. So just as a sideline, you're not going to miss a thing, so we'll both. But one of the things, repetition is the art of learning, so there may be and should be some overlap. But the difference is between myself and Dr. Vinnick's program, he's going to be coming at you from an endocrinology perspective, and I'm going to be strictly looking at from a medical oncology perspective. So you can say that there's going to be some overlap, obviously. When we think about malignancies, we think about certain characteristics that are shown here, and this was published well over a decade ago and has been referred back to many times as putting down on paper what the enemy is. You can't fight your enemy without knowing your enemy. But the things that a cancer cell does are listed here. And we know when we talk about neuroendocrine tumors, some of them, a lot of them, are benign. And the neuroendocrine cancers, all of them basically are malignant. So all neuroendocrine cancers are neuroendocrine tumors, but not all neuroendocrine tumors are malignant. That's a critical component in learning, because when we look at, let's just say, bronchial neuroendocrine tumors, most of those are benign, but about 20 or 30% of them are not. And the ones that aren't behave more aggressively than the neuroendocrine cancers that start somewhere else. So we have to really know our enemy. About 3 years ago, the NIH had a conference of experts that listed 13 different items or topics in which, should they be addressed, would move us further along the road in improving the outcomes in neuroendocrine tumors. And this is a paper that was subsequently published in the Journal of National Cancer Institute in 2008. And I'm just listing here some of the things, but one of the things, the third one down, is the development of cell lines and animal models. And you keep hearing this zebra theme, right? Well, actually, the zebra is not a good animal model for neuroendocrine tumors. This is a joke, guys. This is a joke. This is a book you can go and read about why zebras don't get, actually the title is ulcers, why zebras don't get ulcers. I had to take a little bit of license to, and I don't really think they get neuroendocrine tumors either, but the book doesn't address that, but maybe some person in the room, particularly maybe Dr. Woltering, can write such a book as why zebras don't get nets. Have you heard of this book, Gene? No. Why zebras don't get ulcers? No, but it's really, you think about what?
I think I want to become a zebra.
Oh. You know, the whole gist of this book, and it's kind of like telling you the end of a movie, but why zebras don't get ulcers has to do with stress. And you think about what stresses a zebra has, basically running from tigers, right? Not LSU tigers, but tigers. And so their stress is sudden, and then they're gregarious social creatures, exist in groups. Sort of not the ongoing continuous stress that primates like ourselves may have. So that's part of the message that this scientific writer Dr. Sapolsky actually gets across in this is how we deal with stress and how it's different across species. So on a more serious note, this is, quote, all serious, but going back to being more serious, if we go back and identify the molecular therapeutic targets, and that's kind of what my program today is, what are the things that are new? So that's the focus. And to look at the wiring of the cell, and this is not a complete wiring diagram. In fact, this is a very minuscule part of the wiring diagram of a cell, or neuroendocrine cell, we may say, may have some of these elements to it. But what we do know is that the cells have signaling pathways. And that's you might say, in some respects, a fancy term that it gets used a lot these days. But what we talk about a signaling pathway would be a connection from something that we would call an effector, something that's going to cause something, and then the end of that pathway is a result. So this diagram shows several effectors, some on the membrane for purposes of this paper that published this just a few days ago in Cancer Discovery. This is a new journal from the American Association of Cancer Research. And Dr. Capdevila and his group put together this diagram for neuroendocrine tumors, where we have a somatostatin receptor, the subtypes 1 through 5 represented, a different type of receptor complex, the IGF-1, and the FGF, or the IGF stands for the insulin-like growth factor 1 receptor, would be the R. FGF would stand for the fibroblastic growth factor receptor, type 3 in this case. VEGF would be vascular endothelial growth factor. EGF would be epidermal growth factor receptor. And these other pathways, Notch, Wnt, Hedgehog, and TGF-alpha beta, these other pathways that have been shown to be present. And when the signaling occurs, then there's basically gene alteration in the nucleus, and that alteration could be suppression or activation. So if we just take one of the pathways, let's say the epidermal growth factor receptor, we know that when we inhibit that particular pathway, approximately 50 genes are either turned off or turned on. You can see it's a very complex type of enemy that we're facing. The other part is that we can categorize tumors into smart tumors and dumb tumors. Why do we do that? Well, dumb tumors would be tumors that we could say are dependent or addicted to one particular pathway. An example of this would be a tumor like chronic myelogenous leukemia, or CML, another rare disease. But a little over a decade ago, Brian Drucker and colleagues at University of Oregon Health Science Center in Portland figured out that if they blocked one of the signaling pathways in CML, they could basically convert a chronic disease or a lethal disease into more of a chronic disease. It's really the diabetes model. Even today, in 2011, at LSU in New Orleans, our group still follows patients enrolled in the original trial that started in 1998. They still haven't even gotten close to a median survival. It's 12, 13 years later. In fact, some people talk about CML not even being cancer anymore. Isn't that amazing? Chronic myelogenous leukemia, not a malignancy. That's sort of a lighthearted comment. But the management of CML can be done, some people argue, by someone who's not necessarily a specialist, hematologic blood specialist. So if somebody that's not subspecialized can take care of malignancy previously lethal, that's a dumb tumor, right? You don't have to have somebody really, really super intelligent taking care of it. And then you have smart tumors. Smart tumors are going to figure out where the block occurred, and they're going to go around it. So that's what we're faced with this wiring diagram. We block it at the somatostatin receptor, we block it at other receptors, and after a period of time, the tumor figures out a way around that block And it's up to the specialized person that focused on the disease to kind of figure out what that tumor is going to next behave like, how can we go after it. The problem that we face here is when we start blocking multiple of these pathways, we get into significant adverse effects, and that's some of the frustrating things that we're faced with right now. Traditional treatment options in the management of neuroendocrine tumors is really where the different specialties come together. Surgery, medicine, therapeutic radiology. I'm focusing on these three things because these are the places where we look to, after we do the diagnostic component, we look to these areas for therapy. It's quite a rivalry in medicine between surgeons and fleas. Is that right, Gene? Surgeons and fleas, is that what we get called? Blades and fleas. So this is something that's gone on forever, and there's always the contention of who works for who, right? Last week at a conference, I heard that the surgeons work for me. Is that right, Phil? You know, Dr. Bordeaux is how he was Boudreaux, but he was introduced as Dr. Bordeaux, but that's probably never happened before, has it? He introduced himself as working for me, and all of a sudden I said, holy Moses, a surgeon working for a medicine guy. That's unheard of. You know, he's a technician, right? Just a technician. Just. You always have to put that just in there. But actually, we look at that and we have fun with it, but in all reality, we're working for the patient. That's what it's really all about. You know, we can have fun and say, all the drugs in the world is not going to cure that tumor, because that's the only curative way we can treat these. We can catch them early enough. And then we can flip around and say all the surgery in the world is not going to cure something that now is a chronic disease like diabetes or like CML, where we can use medical therapy or interventional therapy to assist. So it's really not that one's better than the other. It's just that we all work together, and we work together for one common goal, and we all keep that in mind. And I'm going to have this as kind of a recurring theme through this program so that you kind of know where I'm coming from. The emerging treatment options, to kind of get to the emerging part, I want to spend a little bit of time to talk about where we've been, some of the history of the emergent. So this talk says new, but it's going to incorporate old as well, because old now is becoming the new. So we can list on one column, I'll call it column 1, the targeted agent, and we can list on the other side non-targeted agents. And one of the things that medical oncologists like to do is alphabet soup. One of the reasons I went into medical oncology so we can have fun coming up with names for regimens. That's a lighthearted comment. But when we start mixing targeted and non-targeted, or targeted and targeted, or non-targeted and non-targeted, you think of any kind of mixture, we'd like to have some rationale, because when you start increasing the parameters here, the combinations become endless. So we like to have some rationale for doing things. So before we move on to the targeted agents, I'm going to spend a little bit of time on the non-targeted agent, and even going back to the paper that our good friend Irv Modlin at Connecticut, New Haven, Connecticut, Yale, put together. One of those goals is to know your targets and to identify new targets. The targets in the tumor cells that we know about, the growth factors, growth factor receptors, the signaling transduction pathways that are listed here, the tumor-associated receptors that are specific to specific tumors, survival pathways. These are sort of like when you get that guest in the home and they don't know when to leave. Cells accumulate and they don't know when to die, and we have to encourage them and move them on. That's what the cell survival pathways are, because we know that malignancies, a component to it is the fact that they forget to leave, they forget to die. The DNA cell division, and that's what we're focused on in medical oncology, are cells that have gone, the genes have, quote, gone wild. And then the extracellular matrix, tumors cannot exhibit their malignant behavior unless they invade, unless they spread. Many years ago, it was found, the discovery in biology is that cells do an organized growth pattern. They have a period that we'll call G0, where they just rest. They're getting ready for division, and to go into division, they go into what's called G1 stage or phase, which is gap 1, and then they replicate their DNA, called the S phase, and then before they split, they go into what's called G2. So we can look at these 5 phases of what the cells do in order to proliferate, to grow, to divide, and think about how our agents may affect the cells at each step along the way. We know specifically that there's heterogeneity across tumors in terms of how much time they may spend in these different phases. G0 being variable from hours to years in some cases. The G1, once the cell has been put into the stimulation for growing, this is a predictable time up to about 2.5 days. The S phase, again, is between a matter of a day. And as the mitotic apparatus gets constructed in G2, then that becomes even a shorter period of time. And then the actual division of cells occurs within 1 hour. So we can look at this kind of biological behavior and adapt it to neuroendocrine tumors by classifying them according to this proliferative index. As Dr. Woltering earlier mentioned, this Cas6-7 index, and sometimes the stain is called MIB, MIB1, MIB1 Cas6-7 index. And what a pathologist may also do is refer to it as the mitotic index. Mitotic index is when a pathologist will just eyeball the high-power fields. And that's considered adequate by the College of American Pathology. They do not actually have to count all the cells in high-power fields and multiply that by 10. So they just look at a few and put a number on it. You can kind of see that's potentially subjective. And the more senior the pathologist is, the faster they take to eyeball it. So we like to see a number because we want to know the difference between 2 and 7, 14, 20, and 60, and 80. We want to know with some degree of accuracy what that number is. The pathology, on the other hand, as they're not involved in clinical decision making, they don't see much value in 2 versus 14 or 2 versus 7. They'll just say well differentiated. They may say intermediate grade, and they say poorly differentiated or high grade or anaplastic. Those terms will go. So the whole spectrum would be related to what the pathologist is going to be saying. Pathologist is going to be looking at specific staining, and this is, Dr. Woltering showed this earlier, what the mitotic cells look like. When we think about cytotoxic therapies in neoplasia in general, we can categorize them according to how they attack the cells, alkylating agents. This whole area of medicine came out of World War II. It's pretty amazing. It was the Luftwaffe that came out of World War II. That Luftwaffe was responsible for giving us the era of modern chemotherapy. And specifically, it was in Bari Harbor, where Guido here is dressed as to the hilt. Bari Harbor in Italy. And the Allied ships were in Bari Harbor, and the Luftwaffe comes in and strafes the Allied ships. One of these ships had nitrogen mustard gas present. As you might imagine, the sailors that were on that ship jumped into the sea. That sea became a bath of nitrogen mustard. And when they did autopsies on these sailors, they found out that their entire lymph system, their lymphoid system, was totally ablated. This would be kind of like being at ground zero for Hiroshima or Nagasaki. And even before the war ended, that event happened in, I think, 1943. And before the war ended, a group in Connecticut, it's interesting, it goes back to the Northeast, under military funding, put together the use of alkylating agents to treat lymphoma. So that's where we get the modern era of chemotherapy that came out of World War II. Antimetabolites, this would come out of the 1950s when DNA was, the structure of DNA and how the life code, how the code for life was uncovered as we moved into the cell cycle and understanding more about metabolism, the Krebs cycle, and for enzymatic conversion of creation of energy. It was found by 1957 that we could use antimetabolites and disrupt normal cell division. And this ended up winning the Nobel Prize for Rosenberg for 5-FU discovery. Mitotic inhibitors, we talked about one of the very last things a cell does is to divide. We can go in with specific drugs and keep those cells, paralyze them, freeze them in time so they don't divide. Anti-tumor antibiotics, drugs that were initially looked at for antibiotic use and then ended up being too toxic, but found to be active in certain malignancies. And then within the last 20 or 30 years, topoisomerase inhibitors, this group of drugs takes advantage of the fact that when when a cell divides, the DNA has to be copied and it's compacted into the chromosomes. And for DNA to be copied, it has to be unwound out of this compaction. And the topoisomerase enzymes are part of that complex for the DNA to become unwound from this densely compacted structure. So if we can block the enzymes that keep the DNA from being unwound, then we can also inhibit cell growth. So there's a true interface across different primaries. If we look at proliferative indexes that are on the low side, we think about the small bowel primaries, some in the large intestines, some in the lung, some in the pancreas, and then the unknown primaries. And then as we move along into the moderate proliferative indexes and into the highs, you can see that there's some, the thymus, there's no such thing as a low proliferative index for the thymus. But the rectal has a tendency to be more either moderate or high. So there's certain ways that we think about the primary and to be thinking about the treatment. So for tumors that have a low proliferative index, we'd be thinking more about hormonal therapy or biotherapy. And then for tumors that have a moderate to a higher proliferative index, we might come up with regimens that would either be strictly chemotherapy, and for some, the moderate, we might end up using both. Some of the problems that we are inherent in dealing with a rare disease is that the amount of information available to us in the literature is limited. And most of this comes to us from anecdotal or small series that are called retrospective, often single centers. They obviously can't be blinded. They use historical controls. So we don't look at these as necessarily being, creates a new paradigm necessarily. And then the variable methods, how trials are done, endpoints, medicine changes. Before CT scans, a lot of emphasis on physical exams. And then are the things that we choose as surrogate markers, are those things actually predictive of true activity? How large samples are in trials certainly influences what we call the power. And then studies in high-risk subjects are lacking. If we go in and cut out a neuroendocrine tumor and there's lymph node involvement, we know that there's some risk for that person not having been cured. And we look at that as micro-metastatic disease, but not everyone. And so how do we go about treating those people? And that becomes very, right now, becomes not directed by any evidence. When we think about where drugs are in development in the early phases, we might say first-in-man drugs would be phase ones. We don't know the safety. We're still looking at what doses may be. And then as we move into phase two, we're confident now, or more confident in terms we think we have a dose, or at least a dose range identified, and we're interested now in specific disease types. As we get into phase three trials, now we're changing the standard of care. And so as we go from phase one to phase two, more people are involved, are necessary in order to prove the hypothesis. So for phase 1 trials, you may only need a small number, depending upon what the toxicity and what the treatments are, but maybe under 30, sometimes under 20. Phase 2 trials are frequently larger than that, maybe 20 to 60. There's some phase 2 trials that are hundreds. And then phase 3 trials are typically hundreds to sometimes thousands. And then phase 4 trials would be those that the FDA requires simply for safety. They don't ask a question other than or have we identified any additional safety signals. Phase 4 trials are looked at as more marketing. They don't randomize. They just basically get someone to use their product and to record case report for them. So it really becomes more safety than it does efficacy. The phase 2 trials that have been done in well-differentiated neuroendocrine tumors are listed here. Matt Kalki had published this a few years ago. It hasn't changed that much because these agents that are listed here are largely not used. Streptozotocin that is listed does have the only approval, and I've moved this up to islet cell now, for chemotherapy in neuroendocrine tumors. It's basically streptozotocin in islet cell, not streptozotocin in carcinoid. So you can see here the median overall survival with the strep-containing regimens, and notice that there's not any single agent streptozotocin trials. They're even given with 5-FU, 17 months, or given with doxorubicin or adriamycin. And there, the median, you can see there that they didn't report the median overall survival because of the irregularity in doing research. But the response rates, how many tumors actually shrank by 50%, was recorded at 6%. And then this last study I'll mention is the group at MD Anderson. Korvaraki in 2004 published a series of 84 subjects where the response rate was 39%, median overall survival of 37 months. And I want you really to focus on that, where we're using a drug called streptozotocin. It's a islet cell poison. It's got kidney side effects. It's a very strong emetic. It's a drug that many of us don't use anymore. I don't think I've written a dose of streptozotocin. It's been about 4 or 5 years, and I was forced into doing it at that point because of the circumstances of the situation. So when MD Anderson usually does kinds of trials, they usually are very aggressive. So you can see doing triple agents is sort of their forte. This was not a randomized study. They just did everybody with streptozotocin, doxorubicin, or adriamycin and 5-FU. And just remember that 40% response, 39% response rate, because we're going to visit that in another trial here in a second. Now, if we look at randomized trials that have been done, these are frequently done by cooperative groups. Cooperative groups are funded by the National Cancer Institute. They've been around since Nixon declared the war on cancer in the early 70s. So when cyclophosphamide was compared against strep 5-FU, et cetera, you can see there's a theme here of where they're just kind of taking what drugs they think might have activity and seeing if they can refine that. And the numbers that you see are in the 40s to 80s and up to 88 in the doxorubicin 5-FU. But overall, really not too much of this is done based on this work. Median survivals up to 24 months in one series, but ranges from a year to 2 years, we can say. And again, these are advanced metastatic situations. What we can say about treating with cytotoxic agents, they have activity in high to moderate proliferative index situations. In poorly differentiated, would be looking at etoposide or VP16 and platinum, irinotecan, platinum, cytoxin, adriamycin, vincristine. For pancreatic neuroendocrine tumors, would be looking at DTIC or temozolomide and streptozotocin, and then less likely 5-FU by itself, and then very rarely in many centers adriamycin because of the cardiac side effects. When we use treatment, this cytotoxic therapy for high proliferative rate neuroendocrine tumors, we expect to see a response within several months. It doesn't occur within several weeks. The duration of the response usually is somewhat less than 6 months, sometimes longer, but usually what we anticipate would be about a 6-month benefit. The toxicity of these agents are cumulative. The more agents we use in combination, more toxic, and we have to balance what the disease is doing versus what the treatment's doing. These would, for the large part, be considered non-curative. In the refractory state, we would be thinking that it would be less responsive. And then when we do have someone at high risk, we normally don't come in with adjuvant therapy when the drugs are toxic, simply because they're not as active as they want them to be. So now, moving on to other areas, the somatostatin analogs, or what I call the TIDE drugs, a good way of remembering them. The somatostatin has anti-secretory effects. This has been outlined over the last 30 years to be a G-protein coupled receptor that ends up inhibiting cyclic AMP, inhibiting the calcium channel, stimulating the potassium channel, which also inhibits calcium and decreases hormone secretion. So we've all, who do this work, we've all seen responses. This is a patient on the top part of this. It actually failed chemotherapy. And on the bottom parts, it's just strictly 2 months later with just somatostatin therapy. So nothing else changed. And you can see that the tumor sizes on several areas are smaller. This went on to where the Germans published a multi-center study that was prospective, randomized, and blinded a couple of years ago, where they randomized patients between the somatostatin analogs and placebo injections, and these were people with well-differentiated midgut or intestinal, for the most part, neuroendocrine cancer with minimal amount of disease in the liver, minimally symptomatic. So it'd be hard to do this in most centers where people are having carcinoid syndrome symptoms. So that same time, by the time they got that observation that you could use somatostatin analogs in more than double the length of time to progression, it doesn't really tell us when to use them. We know to use them when there's symptoms, but we don't necessarily know, other than symptoms, of when to use them. We just know that it prolongs, doesn't cure. The National Cooperative Cancers Networks came out. This is a guidelines that many oncologists use, and the third line over, within a short period of time, they incorporated in people who were asymptomatic, because symptomatic patients already had octreotide in it. And so this PROMID data gave us octreotide in the asymptomatic setting, simply because of the delay in progression. Now, coming up with new tides, octreotide mostly hits subtypes 2, 3, and 5. Somatostatin, native hormone, hits all 5, and then this drug, Pasireotide, hits 4 out of these 5. Unfortunately, Pasireotide it's in the investigational state, but may come out either later this year or next year and be in the realm of Dr. Venick and Dr. Odoricio for pituitary tumors. How it's to be used for carcinoid syndrome control, study going on right now to define that. It's going to be a while before we know. Using this potent inhibitor of IGF-1 in combination with other drugs is something also being looked at right now. And using it as an imaging agent also is being looked at. Moving on to the mTOR inhibitors, I'm going to call those the limuses. These agents are useful. It comes to us from the transplant world. They are immunomodulatory. They can create a defect in the immune system. For the neuroendocrine tumor, there's a very specific downstream target called mTOR, mammalian target of rapamycin, that when Everolimus binds to the binding protein, inhibits the binding, binds to FKB12, with that, there's inhibition of that mTOR pathway. So one of the things that we know about neuroendocrine tumors is that this pathway is turned on automatically. And so what Afinitor or Everolimus does is inhibits this constitutively active pathway. So without Afinitor, it would be like you go to the wall switch in the room, you turn it off, and the lights are still on. The cell has lost its normal regulatory behavior. Now, with Everolimus, we have reestablished that connection. We turn the lights off. We see the cells behaving more in a normal fashion. And then looking at not only the Everolimus, but also the rationale for VEGF expression, vascular endothelial growth factor. For neuroendocrine tumors, the ones arriving, the well-differentiated from the midgut, 70%, the islet cells, nearly 100% express this. Earlier this year, a paper was published in the New England Journal for both VEGF inhibition, the Sunitinib, and for mTOR inhibition, or the Limus drug. These papers came back to back, and this is one slide that shows the results of both. The time for the tumor to progress on scans is the same endpoint that you saw in the PROMID study, and this is what we saw for Sunitinib. The placebo arm took 5.5 months, and again, these are pancreatic primaries. These are people who have failed at least the first line of treatment, so somewhat resistant. And then when Sunitinib or Sutent was given, 11.4 months, and then for the progression-free survival for the RADIANT-3 trial or the RAD-001 or Everolimus, about the same. The control, placebo, 5.4, it's amazing. These were totally different trials done. The Sutent was more in Europe. The RADIANT-3 was more global with more emphasis in North America. And the control arm, the investigational arm, 11.4 months. So both of these agents, these trials were done at the same time. Both these agents were approved within a matter of a few weeks in May of this year. One of the other things that studies look at is overall survival. Sutent, the reason they were able to see a survival difference because they took the patients off the trial and put them onto another trial. RADIANT-3, they continued them on the trial and reported as they crossed over, everyone got the same drug, no benefit in the overall survival, as you'd expect, because there's no comparative arm. The most frequent side effects, I think this is what concerns all of us. We do get some benefit out of these drugs, but what price do we have to pay? With the Sunitinib, you can see as it goes down in numbers, the diarrhea, the nausea, the asthenia, vomiting, fatigue, hair color changes, neutropenia, abdominal pain, blood pressure elevation, hand-foot syndrome or palmar-plantar erythrodysesthesia, anorexia, stomatitis. And then on the other side, we can see Everolimus versus placebo and see the differences here between diarrhea, nausea, asthenia, vomiting, fatigue between the two agents, and then some that are very specific for the agents. For the Everolimus, we see stomatitis in a high frequency, 2/3 in terms of all grades. If we look at this continues down this stops at 22, this continues down from 20 down to 16, et cetera. And you can see there's continuous differences a bit. We do see elevated blood sugar on the Everolimus, and we'll see more hypertension on this slide with the VEGF inhibitor with Sunitinib. But diarrhea, skin rash are some of the things that are common. If we look at some of the severity, and this is where we would have to stop the treatment, delay the treatment, or dose reduce. These kind of side effects, we might do that for diarrhea for both of these agents, nausea to a limited extent, asthenia, vomiting, fatigue, et cetera. So you can see we can adjust the dose so that very few people actually end up getting sick to a point where we have to interrupt treatment. And again, these are it goes on. The summary for the Sunitinib in patients with progressive, well-differentiated pancreatic neuroendocrine tumors, continuous dosing of Sunitinib at 37.5 milligrams, what the trial did, double the median progression-free survival, and this was independent of any specific subgroup analysis. For the Everolimus, again, published in the New England Journal, the 10 milligrams daily dose resulted in median progression-free survival 4.6, again, in the progressive patients. So what we do know is that the dosis facit venenum is that it's the dose that makes poison. We have to adjust, this is the art of medicine, we have to adjust the dose to the patient. We don't do it the other way around. And this is some of the things that do come through pathways in what we hear a lot about is that we can't just go and say one dose necessarily fits all. We do have to take into consideration drug-drug interactions and people's individual sensitivity to them. The future, what we want to be moving towards is taking a tumor and looking at what the targets are, potentially We could say that the heterogeneity, the targets may be different from the primary versus metastatic sites. We'd like to develop what's called molecular profiling. Where we are at this point, we've got better imaging agents, and we'll be seeing more scanning with PET isotopes. We'll be using treatment as it moves into this country in phase 3 trials with the yttrium-90 and lutetium-177, and then using radiation sensitizers with therapy such as MIBG with 131. I-131 is the MIBG I-131 is a way of treating neuroendocrine tumors that have the catecholamine transporter protein. I haven't talked too much about that, but it's another way we can characterize these tumors. About 2/3 of the well-differentiated midgut carcinoids will express this protein, whereas in pheochromocytomas, these tumors arising from the adrenal, nearly 90% of them will. So MIBG therapy is something that has been done now. It started at the University of Michigan. It's been done now for over 20 years. We have a lot of experience with it. Tyrosine kinase receptors inhibitors will be part of the future, more understanding of how mTOR inhibitors can be used in combination with other agents. And this is a list, again, going back to the cancer discovery paper just published last month, just a ton of different trials that are agents that are in development that would be considered targeted, in this case, anti-angiogenic. And clinical trials that would be coming to us from clinicaltrials.gov. You can see a lot of activity for a rare disease that's ongoing, looking at the mTOR target, looking at the epidermal growth factor target, insulin-like growth factor. You can just go down and just see how focused a number of different companies, institutions, principal investigators are in looking at this. I just sort of like to end this to show that this carcinoid race car is our motto in terms of racing for a cure, in this case a cause. We can't get to the cure until we establish the cause. And the number for the car should be 209, which is the ICD-9 classification, to clearly identify what our target is. This would be the side view of that race car. Being in Indianapolis, I can't think of a better place to demo this race car. And as an inside joke, Gene, my other car is a red truck, and this is in deference to Dr. Woltering, who does drive a red truck, pickup truck. It reminds me of the politician. The first thing you do when you run for political office in the South is you get yourself a red truck. You know, Fred Thompson did that in Tennessee, and you get you a plaid shirt going, and you get lots of flags, on you, and you drive a red truck, and you're ready for run for political office. So we'll just stop right there and.